All right, I want to talk about treatment. Let's talk about, I guess we've established the diagnosis. Now we're going to deal with this, and it's non-trivial, in my experience anyway. When you're going to initiate therapy in a newly diagnosed patient with C. diff, can you divide patients into groups? How do you start? How do you make decisions?
Well, the previous guidelines definitely were focused on severity of the C. diff diarrhea based on whether your creatinine was 1.5 times higher than your baseline or your white blood cell count was 15,000 or more. The new guideline really doesn't differentiate as much on the basis of severity. Instead, the recommendation, the big change is that metronidazole, which had been kind of a workhorse treatment drug for the past 20 years, is no longer recommended as first-line therapy.
In either case?
In either case, but if the patient has non-severe disease and the recommended therapy now is either vancomycin or fidaxomicin for these patients, but if you have difficulty accessing those drugs, which are more expensive, and when the guideline says accessing, that is code for I can't afford vancomycin or fidaxomicin, or I can't get it approved by my insurance company or whatever it is, then metronidazole could be used for these non-severe cases only, and not for severe cases.
Why is metronidazole out? Is it less effective? Does it not work? What was the problem?
We finally got a good prospective, large, blinded trial of metronidazole versus vancomycin. And it finally showed that metronidazole is inferior to vancomycin across the board for all patients. All right. And that was the convincing piece of data. And I have to say that we did one of the first trials in 1983 of metronidazole, could see no difference between metronidazole and vancomycin, but the trial was not large enough. And we mistakenly said, these are equivalent drugs. We should never have said that. It was a big mistake. And now we have enough data that and metronidazole, by the way, never went through FDA approval as a treatment agent.
It was always off-label?
It was already a generic drug by the time it was tried, and so it never went through the process.
So you're telling me that you did something almost unheard of in medicine. You got good data.
Exactly.
And the good data convinced you that metronidazole was not the way to go.
Exactly.
All right, that's pretty straightforward.
And it could also be, by the way, that metronidazole doesn't make sense that much for C. diff because it's a systemic antibiotic and C. diff all happens in the gut. But it can also be that some of the strains that we've seen emerging are less treatable with metronidazole. They cause more severe disease, they're less susceptible and so forth. And if there is any resistance to any antibiotic, reported not very often, but reported, it is to metronidazole far more often than any other.
Let me turn this back around. Maybe you were just fine with metronidazole at first, but the landscape has changed, the bacteriology has changed, and what we're seeing now is bugs that are less sensitive to metronidazole than they were.
The first part is correct, the last part is not. So the new strains we think are not as likely to respond to metronidazole as the previous strain, but I don't think you can blame it on resistance to the drug. It's something else, and we don't know for sure what it is, but clearly metronidazole is not working as well beginning in the 2000s as it did for the previous 15 or 20 years.
Okay.
So I think the strains are different, and I think it clearly is a changing landscape.
I like to make a distinction between microbiologic resistance and clinical resistance.
Fair enough.
Microbiologic, there's not much evidence of microbiologic resistance in the Petri dish. But in the patient, there's multiple studies, the randomized controlled trial, but also multiple observational studies showing up to 35% of patients don't respond to metronidazole. So clinically, there is resistance.